Good afternoon, ladies and gentlemen. Myself, I'm Dr. Mandeep Kaur, Fellow DNB from Indraprastha Apollo Hospital. Dr. Arun Prasad couldn't be here today for the presentation, so I'm presenting on his behalf. My topic of presentation being the role of sympathectomy in peripheral vascular diseases. Well, a lot has been said and talked about the peripheral vascular diseases, and so we have a couple of options when we talk about peripheral vascular diseases. The first being the medical management, complete cessation of smoking if the patient is smoking. There are other options of the drug treatment, there are surgical options, and last comes the role of sympathectomy, which is going to be my topic of presentation today. I'm going to talk only about the sympathectomy part. Now, sympathectomy constitutes a surgical alternative in those cases with the extremity viability that depends on the collateral circulation, and the arterial surgery is not possible. So what happens is that these are the group of patients where we have exhausted all our medical options, drug treatment is not working anymore, surgery cannot be done, and we want to reduce morbidity in these patients, and we want to save limbs, or we want to reduce the pain. These are the patients who are taken up for sympathectomy. When I go through the literature review, there was an article published in Journal of Angiology and Vascular Surgery that talked about the impact of lumbar sympathectomy, and it talked, they did a lumbar sympathectomy in patients, and they assessed the blood flow post-sympathectomy by laser Doppler flowmetry. And the results said that the sympathectomy, it elicits the activation of microcirculation in all tissue types. And this is what helps us save the limbs. This is what helps us lower the level of amputations. Another study which was done to elicit the same thing, it talked about the effect of lumbar sympathectomy. And it says a beautiful thing that the lumbar sympathectomy, it represents a chance in these very delicate patients, a delicate group of patients, because of these specifically are the patients where we have exhausted our medical options. We don't have many surgical options. So morbidity is definitely going to be there. But how do we reduce that level of morbidity? That is where the role of sympathectomy is. So now coming to the indications of sympathectomy, the indications of sympathectomy, so they are limited. In the patients who are going to benefit, who are going to have definite benefit from sympathectomy are the patients who have rest pain which is not responding to medical therapy anymore, or the patients who have non-healing ischemic ulcers. These are the patients where we do sympathectomies and increase the chances of healing of these ulcers to lower the level of amputations. Because as I've mentioned before, that after sympathectomy, the impact of sympathetic system is gone. There is vasodilation, and there are chances that we can lower the level of amputations. The above knee amputations can be converted into below knee amputations. To increase the claudication distance, and sympathectomy has seen to have definitive benefit in Raynaud's phenomenon. It increases the chances of healing and taking of grafts. In causalgia, the sympathectomy, it has definitive benefit, very good procedure for causalgias. Another indication beyond all this is hyperhidrosis, where with the introduction of visually assisted thoracoscopic sympathectomy, the morbidity in this patient is lower and the effects are very good. Another article that was published in Journal of Anatomy, it says the lines that are colored red, these are the indications: the pulmonary hyperhidrosis, complex regional pain syndrome, and the Raynaud's phenomenon. These are in fact the places where we have found that sympathectomy has a very good benefit. So I'm going to talk about two procedures from the surgeon's point of view: lumbar sympathectomy for lower limbs and thoracic sympathectomy for upper limbs. I'll take my medical friends through the surgical part of the treatment. How do we go ahead with the procedures? This is a video, a very short video, just 2 minutes video, that talks about endoscopic thoracic sympathectomy. In this video, right now we are in the left chest, and you can all clearly see the back surface of the chest, and the white structures out there, they are the ribs. This is the left lung, and you can see my cautery hook. It's showing the third rib and then the fourth rib. See, the point is, first rib is very difficult to visualize thoracoscopically. When we enter the first rib, that is very clearly seen is the second rib, and then comes the third rib and the fourth rib. Now we are tracing the sympathetic chain. That white structure that is following my hook is a sympathetic chain. There are various levels of sympathectomy we can do. We do sympathectomies at T2 level, T3 level. In this particular indication, we prefer T3 and T4 levels, T3 specifically. T4 level, that supplies the facial blushing, and there's a treatment for patients who present with facial blushing. T3 level is for Raynaud's phenomenon or the patients who present with hyperhidrosis, because T3 is the level that supplies the upper limb. So here we are seeing the chain that is free from all the sides, and with the simple cautery hook, we divide the chain at T3 level. And there is this bleeding that we can see is very minimal. It's, if you see that in open, it's nothing. It's very important to cauterize the nerve of Kuntz. That is the major reason for recurrences in these patients. This was about thoracic sympathectomy, which is done for the cases of Raynaud's phenomenon. It shows beautiful effects, and it is done for hyperhidrosis. Then now I'm going to talk about, I'm sorry for the spelling mistake, I'm going to talk about lumbar sympathectomy. Here in this video, we're showing entering into the retroperitoneal space. Excess is created from the anterior axillary line, and we make 3 ports enter into the retroperitoneal space. Now here in this video, we are dissecting the retroperitoneal space. In fact, the retroperitoneal space is dissected as soon as we start creating, as soon as we start inflating it with carbon dioxide. Then here we come across psoas. There is a fat that is present. Retract the psoas muscle up with the retractor, and my suction is pointing towards the psoas. Important point in this procedure is identifying the ureter, which is going to run just parallel to the sympathetic chain. Once the ureter is identified, as you can see that the suction is pointing at the ureter. Once the ureter is identified, the very important step is to lift up the ureter. Once you have lifted up the ureter, you will see sympathetic chain right in front of your eyes. This is a lumbar sympathetic chain, L2 level. L2 ganglia are larger than the rest of the ganglia, so it's easily identified. And once the sympathetic chain is identified, we free the ends of the lumbar sympathetic chain. One catch here is, while doing the sympathectomy in the lumbar region, there are lumbar veins that are supplying the chain. So it's important to catch hold of those veins and cauterize so that you don't face any bleeding in there. After freeing the top end, we take out the bottom end and take out the ganglia, and that is sent for biopsy to confirm that it's a lumbar chain that is dissected. Here in this video, we are removing the specimen, which will be sent for biopsy, check for hemostasis, and that's it. We're done with the procedure. Now this is a stepwise presentation of what all we have seen. Identify psoas in the fat, lift up the fat, identify ureter, and then lift up the ureter above, identify the ganglion, divide it and come out. Again, going back to the topic that the literature review that we saw, as I mentioned before, that the pulmonary Palmer hyperhidrosis is a point where there is definitive benefit of sympathectomy. Then the other places are regional pain syndromes and the Raynaud's phenomenon. It is definitely helpful in reducing the morbidity. The procedures are not relatively the procedures are simple, and with this minimal access techniques that are available these days, the morbidity of the procedure itself is not very much. In our experience, we have done 6 cases of lower limb non-healing ulcers. 3 of those ulcers have healed very well. The point is that in lower limb, the sympathectomy does not have as much benefit as in upper limb cases. Like in 2 cases of rest pain, 1 patient was absolutely pain-free after the procedure, and 1 patient had reduced pain. And in cases of Raynaud's disease, we would have done 11 cases of Raynaud's, and 9 patients of those benefited very well. And of these 9 patients, 2 had ulcers that healed. And to add a line, hyperhidrosis patients, it's not related to the peripheral vascular disease, but hyperhidrosis patients, they benefit the most out of the sympathectomies. Thank you.
Yeah, hi.
Very much. This paper is open for questions.
I just want to ask you a simple question. Do you think with the advent of technology in the last few years, I thought these procedures are totally obsolete, both these procedures?
No.
Really?
There are multiple options, but then, as I've mentioned my slide on our experience, I did not talk about a large number of cases. We've done just 6 cases in, so the indications have decreased. There are other options. There are other multiple options and other very good options that are available. But
do you know of any other option which all these sympathectomies can be done very much simpler way? Do you know any other option where all these sympathectomies, they can be done in a much, much simpler way?
So we do it this way, the minimal access approach.
Yeah. Do you know a much more simpler approach? Any idea?
What's that, no?
Okay, this is something called an ultrasound guided.
Okay.
So you puncture and the CT guided.
Yes.
It takes around 10 minutes to do it, and patient walks home.
Okay.
It's done under local anesthesia.
Okay, all right.
Can you explain, doctor, a little bit more on what you're saying?
I'm Dr. Vinay Krishna from Cardiology Institute, Kanpur. Do you remove the part of the cervical sympathetic chain or just divide it as you show?
The thoracic sympathetic chain at T2 level, we divide it and leave it, and we make sure to burn the ends and divide the nerve of cones.
You don't excise the ganglion in thoracic?
No, it's not required, no.
Okay. Which doctor is telling is that previously it was done blindly, that 6% phenol injection was given for cervical sympathetic chain and also for the lumbar sympathetic chain. But with the advent of these ultrasound guidance, this technique has become more
so that was the point of my showing the surgical techniques, the thoracoscopic way of, because we are doing a lot of cases, endoscopic thoracic sympathectomy, a lot of cases for hyperhidrosis, a lot of those. I mean, as in the cervical sympathectomies, they used to be blind procedures, difficult to do. But with the advent of visually assisted thoracoscopic procedure, the procedure hardly takes 10 to 15 minutes, and it's done very safely with a laryngeal mask or a single lumen tube. There are no complications.
You see, I have done more than 50 videoscopic thoracoscopic sympathectomy. I used to do from 1999, all these procedures. Okay. So we stopped doing all these procedures around 5-6 years back. And because, you see, if you look at the literature, and there is a Hyperhidrosis Society of America, even if you look at the literature all around the world, there are various serious complications which are associated with this procedure. You have to deflate the lung, you have to give a GA, patient of course can be discharged. Most of the very good centers, they discharge the patient.
So we discharge the patient the same way. There are,
I
mean, it comes to flaunting, but then we have not had major complications. We check the patients thoroughly with GA. I don't think is, it's safe these days, and we do all these procedures. And in fact, the procedures have been done under local anesthesia. We are not doing it at our center. We do it under general anesthesia only. But we do it with Uniport, and we have not had any major complications.
That's great.
Thank you very much for the nice presentation.